what I tried to do as I went through this was not just give you, I don't want to give you just protocols, but I am going to give you a protocol to work with. But I also wanted to give you talking points and also be able to give you the flexibility that wherever that patient enters the clinic at, you can make a quick recommendation. It's not bogging you down, it's not interrupting your flow with the patient, but it's something you can, as you're just conversing with them, as you're going through your care, you can make that recommendation, make that intervention for them. Let me go over some learning objectives here with us at the outset. I do want to go through the phases of healing. We're talking about this with patients anyway. It makes sense for us to figure out ways to implement products in with these phases of care or these phases of the healing process. I'm going to give you protocols around muscular, osseous, and cartilaginous dysfunction. Obviously, the muscular and the cartilaginous is probably going to be the bigger of those two that I'm going to put more emphasis on, but they all certainly have relevance here. The application of the product, I think this is probably of all these objectives, this is where I need you to take the most away from this. And again, a little bit of science, not going to do a huge deep dive into science here, but enough to where we can all be able to have that conversation with the patient. And then getting the patient to follow through. This is certainly, doesn't do us a whole lot of good to put the patient on something and then not follow through or see it through to the end. And I think as I go through this with you, and as I would imagine that this would be implemented or carried out in the clinic, is to me, the things that we're going to be talking about here, this would be part of the conversation from the get-go with the patient. These nutrients, as you look at what your intervention strategy already is, I would just look at how these parallel in with your current strategies. So with that being said, just a quick review. All of us know this off the top of our head. The phases of healing, the acute, the inflammatory. This is those first few days is what we're talking about here. Those cardinal signs of inflammation. This is the heat, the change in the color, the swelling that we're looking at a cellular level. And really what we have to think about is two things here. One, we do want to offset, we do want to calm down the inflammation. We know that this can be a snowball rolling downhill if we don't do something to break that and intervene on that. And as a byproduct, as that inflammation continues to manifest, as it continues to build, that's where we ultimately end up with cellular damage. And in some ways, patients are already coming in probably before they had the injury that they're coming in for. They already have some degree of cellular damage. There's already some systemic inflammation that's playing a hand in this just based on the choices that they're making. So we want to do everything we can to offset that. The subacute phase, this is going to be much longer, and you'll notice on this that we can certainly begin to scale when we move from a subacute to a remodeling phase based on the nature of the injury, the intensity of the injury that individual has. But ultimately, what we're trying to do in this second phase here, the proliferative repair phase, is this is where we want to start looking at how are we influencing the activity of the cells that are going to help manage collagen development, is what we're thinking about here. And then lastly on this remodeling phase, this is where we're going to have to really think about, you guys all know what a challenge it is to get patients to do maintenance care anyway sometimes, right? And so this is really in the same mindset, but this gives us a different tool to be able to intervene on the maintenance side of things until they see it through all the way to the end. On this acute phase, we have a couple of goals here. One, we do want to control inflammation, and we want to, in short, what that probably means is that we want to stop these inflammatory cascades from potentiating. We want to have ways of being able to facilitate the inflammation to the point that it's beneficial, but when it's time for that to slow down, we want to slow that down too. We'll look at how to do that in just a moment. The other thing we want to do is we want to debride damaged tissues, meaning that as that cellular destruction occurs, those cells that are now dysfunctional, we want to support the immune system in being able to identify those cells, clean those cells out, remove those out so that we're not dealing with damaged tissue anymore. This is a key component. And actually, we understand quite a bit more about this than we ever did in the past. It would just make sense from a sheer musculoskeletal application. You don't want a damaged tissue there. It's not a functional tissue, so just from sheer structure and function, let's get rid of it, right? Well, what we know about this now is that the longer these tissues that are damaged linger around, you change the protein structures, and in time, if that damaged protein structure sits around there long enough, you're going to start, the immune system is going to start to recognize that. And this is where you can start to see some of the onset for autoimmunity take place, because now you've got a foreign protein, because it's a damaged protein, that if the immune system sees that for a long enough period of time, it's going to develop a sustained response against it. So we certainly don't want to do that. There's two intervention options that we can look to here. There's the BioLA and the Intenzyme Forte. Now, I will say as I go through this, if at some point in the context of this information, if you and I have a conversation, I may make a recommendation that extends beyond what is simply put in this conversation, but probably 90% of the time, maybe even more than that, these are going to be the products that I'm going to tell you to turn to with patients and to look for. And keep in mind, at a cellular level, what we are trying to do is facilitate the activity of those macrophages, to some degree the neutrophils in here as well. But we want these are the Pac-Man cells, right? That's how everybody knows this cell class is. These are the Pac-Man cells. That those are the cells we want to facilitate and make their job a little bit easier. Pain present. Patient walks through the door, you're trying to scale their pain. You're trying to get a feel for what's the severity, what's the intensity for them. So these are some easy questions we can ask to see if this BioLA makes sense for them. One, I want to know, is the pain affecting their lifestyle? If it is, I need to do something to mitigate that, to one, just get them to be able to do their activities of daily living, but also maybe I need to get some mobility going as quick as possible. And then if I can start to mitigate some of these pain patterns, then I can start to get some of that under control. Is the patient considering taking an analgesic? We know that it's reflexive a lot of times for someone to grab some acetaminophen or some other over-the-counter medication to be able to control the pain, and they start to look for some of those OTC anti-inflammatories. Interestingly enough, and I'll show you this coming up, some of the reasons that we use the compounds in the BioLA are not just for analgesic applications, they're also for modulating the inflammatory cascades as well. And does this patient want an alternative to aspirin? You know, some people come in actually looking, what do you have that's different? I don't want to take aspirin. Aspirin doesn't make me feel good, or whatever the rationale is. But fortunately, in some scenarios now, it becomes easier to have a conversation around these alternatives, and this is a good one to have in your back pocket to initially get the situation under control. This is going to be a combination of 3 ingredients here. The BioLA is going to have a white willow in it. You'll remember that. That's probably of the compounds that are in there, that is probably the one that would be looked at to have the most analgesic, most direct sensation. If I'm trying to modulate the sensation of pain, that is probably the ingredient that's going to have the most direct application on that. Nice thing about this is that, fortunately, if you do need that, if this is a person that tends to go to aspirin, you're not going to run into the same toxicity profile with this as you do with aspirin. Devil's Claw. Devil's Claw specifically, you recall back to that bioprint that I mentioned in the last presentation where you're looking for that exact signature. Notice on this, we've got the specific species that we're looking for here. We're looking at the exact part of the plant and how that was pulled from that plant. So we're being very specific in what we're looking at here. And this has both an analgesic and an anti-inflammatory. So now we're starting to combine modes or mechanisms of action here. But interestingly enough on this, it's also chondroprotective. It's chondroprotective predominantly because it's inhibiting the degradative process against the cartilaginous tissue. As that, I have an illustration of this as we go forward. As that inflammatory cascade increases, you start to damage those cartilaginous structures. This is going to help in offsetting that. You guys also know that one of the reasons that a lot of these anti-inflammatory, the high horsepower anti-inflammatory medications have side effects is because they become very suppressive of particular pathways and disregard other complementary pathways. So instead of bringing down the total inflammatory load in total by hitting multiple mechanisms of action, it becomes very specific, and now you create an imbalance, which ultimately starts to create some of the side effects.
this doesn't have that same type of profile. It's very suppressive to all of the inflammatory cascades collectively. Boswellia, you'll notice on this one's actually coming from the gum of Boswellia. This one is going to inhibit the 5 lipooxygenase pathways, but fortunately here, you're also seeing some hepatoprotective effects, which is actually almost completely counterintuitive to what we think about with other anti-inflammatories that can have hepatotoxicity types of effect. So now you're not just getting the musculoskeletal benefit that you're looking for from this, but you're also getting the benefit of protecting those other tissues. And this can also be a situation where when a patient presents and says, I need to be on that prescriptive medication, there's really no reason that they couldn't be using this as an adjunct at the same time to yield similar benefits, complementary benefits, but also to protect the hepatic tissue in the same context. Devil's Claw, I wanted to take each one of these individually and give a breakdown on this. Notice that we're specifically talking in relation to human research here, but decreased pain in knee and hip osteoarthritis, going back to not only calming down the inflammatory and the pain cascades, but also now we can start to have that intervention that's going to protect the chondrocytes and non-specific low back pain. Wow, that sounds like that's in the chiro's wheelhouse, right? So Devil's Claw would definitely be one that we would want on our short list on this. As far as the dosing here, remember what I said about these compounds. This is starting to be a universal theme. Dose-dependent increases. And I have this in here for you, but just to go ahead and put this out there, an initial dose here would be 3 capsules twice a day. So a total of 6 capsules per day would be an initial starting dose on this. Can you go above that? Yes, you can go above that if it's necessary. So titrate that dosing as needed. Point being on this is that as that dose increases, you're going to have more of a stimulatory effect to these pathways we've been talking about. But notice on this, as a beneficial byproduct, superoxide dismutase, catalase, and glutathione peroxidase, those are our 3 core endogenous antioxidant systems. If we can upregulate those, anytime we can upregulate those, we're going to see an improved outcome. So Devil's Claw is going to be something that's going to help us facilitate that process. Looking at some more mechanisms of action on this, the 2 of the mechanisms of action that are often talked about that seem to be, if you can address these 2 mechanisms, you probably got a winner as far as an anti-inflammatory. One is going to be this TNF alpha, this tumor necrosis factor alpha. If you can have some suppressive effect on that, that is very early in the inflammatory cascades. The other one, which we'll mention later on, is going to be NF-kappa beta, your nuclear factor kappa beta. Not to delve too far off into those, but I do think that those are important cytokines to discuss just because they are so prolifically discussed and talked about now that those are probably 2 that we do need to know about. You'll notice on this that does have some impact on the COX-2 gene as well, or the COX-2 inflammatory cascades. And looking at some of the mechanisms of action, just giving you some graphical impact here, it's going to decrease the leukocyte elastase. Elastase is probably the key word that you need to focus in on here. Reason being on that is elastase degrades elastic. Well, what's elastic in our body? Collagen, cartilage, right? So if we don't get this enzyme under control, that's where we start to see, this is a mechanism of action where we see the cartilage can become damaged. We want to control this. Arachidonic acid, these topoisomerase pathways, this C2 convertase, this is going to be part of your immune cascades that we're talking about here. That these are all either promoting degradation of tissue or inhibiting or potentiating the inflammatory pathways, and your Boswellia has the capacity to inhibit that. Nice thing about this, again, this is the mindset. We're not looking to be so specific with these compounds, and this is, again, a universal theme, is that these compounds are not so specific that they run the risk of creating side effects because they're so overwhelming on that pathway. They seem to hit multiple pathways, and in turn, that creates less of a risk for a toxicity profile. It's also why you can titrate those dosages a little easier too, and sometimes get into these heavier dosages that you need to just to get that initial pain pathway under control, that pain presentation under control. Starting dose on this, 2 caps TID or 3 caps BID. I would say you just use a starting dose of 6 there to make that fairly straightforward. And as that pain the pain becomes more intense, and something else to think about with this as well is you get those patients that come in that have had a chronic pain for an extended period of time. This is probably going to be something that you're going to need to keep them on that, even though we're talking about the acute phase, those initial 72 hours. This can be something that you can keep that patient on for an extended period of time to help modulate those pain pathways. I would integrate in some vitamin D, some omegas to facilitate that as well, since those are proven pain modulators. But if you need the more direct, probably a little higher horsepower, botanical intervention, this is going to be the one to do that with. So it really comes down to just meeting that patient where their needs are at here. Intenzyme. A couple of key concepts on intenzyme, and as the name implies on this, this is an enzyme complex. There's going to be proteolytic enzymes in here. We'll break those down momentarily. But debriding, taking that tissue, cleaning that tissue up, trying to get rid of the damaged cellular structures to where we can replace that with new healthy structures. We're driving the activity of those macrophages. There's going to be direct anti-inflammatory activity. As these inflammatory cytokines are released, and we do this, the macrophages, a lot of the ways that this works is when a macrophage goes into an area and it starts to initiate and clean up that area. Remember, those monocytes are circulating. They're always circulating in the blood. The inflammatory insult's initiated. Those monocytes go into an area, become macrophages. The macrophages start to clean up, and then they're going to send out cytokines. And those cytokines are what are going to help bring in the other cell types to really clean that area up. In the instance where that becomes problematic, the enzymes, these proteolytic enzymes, because these cytokines are peptides or protein-based structures, you're going to see inhibition of that cytokine activity, and the likelihood that that inflammatory pathway is going to continue to escalate is drastically reduced as a byproduct of this. Catalyzes protein hydrolysis. Fancy way of saying it just breaks proteins down into smaller structures. And then this proteolytic formulation here, we would probably think about this for the context of our applications. We would think about this more in a local injury, hot back, hot neck, maybe a sports injury, something of that nature. But this can also be used in systemic applications as well. So that patient that does come in that already has some type of inflammatory cascade, some type of systemic dysfunction that's underlying this, it's exacerbating this presentation, this can be added into a protocol for them, used at a lower dose on an extended period of time to bring down that inflammatory situation. Just for those of you that are interested, I did want to put in here the two areas where these proteases work. We have some proteases that are working at serine. We have some of them that are working at cysteine. These are just the bonds that they're breaking, is all that says. What is likely more important for most of us is that if we look at enzymes like chymotrypsin, trypsin, elastase, these are going to be ones that are, especially the chymotrypsin and the trypsin, these are going to be the ones that have a long track record of being efficacious in terms of how they knock down inflammation. And then many of you are going to be familiar with things like papain and bromelain. Admittedly, I wasn't terribly familiar with physin, but physin, do a little research on that one. You find out pretty quick that physin's a pretty right in line with what we think about with bromelain and papain as well. So those are going to be the enzyme complex that you're looking at. Idea with this is that because you have multiple different proteolytic enzymes, they're going to have the capacity to work in multiple different environments, and you can see that they're going to hit different points in that degradation process of trying to clean up that dead or damaged tissue and debride that out. So your general applications on this, the systemic inflammation, tissue damage, arthritis, and for individuals, this would probably be the additional concept to consider here when there is poor circulation into an area. If someone, again, maybe has something of a chronic nature and you need to enhance blood flow into that area, this is something that can be done, assuming that they don't have any type of blood coagulation concern. Your dosing here, dosing is a little unique on this one, so make note of what is on this slide. This is going to be something that we want to front load. We want to add 10 of these in right at the outset. Let's get the systemic or circulatory levels of these enzymes up. And then once we've got these enzymes up, and again, this is more acute, 5 tablets 4 times a day on an empty stomach. Empty stomach being critical here because we want to make sure that we're not utilizing this and digesting food with it. We want it to go into systemic circulation to provide benefit. And then as things begin to calm down, we're going to titrate the dosages down. We're going to be able to bring that down. We go to, instead of 5 tablets, we'll go down to 4 tablets. Instead of 4 times a day, we'll go down to 3 times a day. And really, I would say just use your clinical judgment, use your observation, and at the point that you feel that that patient's inflammatory situation is under control, they're well into the second phase and definitely into the third phase of healing, then you can start to look at weaning them off of this. If it is a chronic situation, you may even go up, you may stay at a higher dose just depending on what the need for that individual is. But again, key point on this is make sure that that patient is using that on an empty stomach. A good rule of thumb to apply here, 30 minutes before a meal or 2 hours after a meal is essentially what you want to look at. I always tend to go with 30 minutes before a meal. Patients just seem to do much better with 30 minutes before a meal.
On that 10 tablets immediately, you're saying so they take 10 immediately and then start the 5 tablets
Yes.
4 times? Okay, so they're essentially taking 30 tablets that first day?
That first day.
Okay.
It's a heavy,
500 count bottle.
yeah, it is it's a heavy dose the first few days.
Yeah.
Yeah. And it may be even a situation on
They are.
those 10 tablets in that acute injury. It's probably a good idea to have them do that before they even leave the clinic.
Yeah, okay.
A couple of other options on this, and again, think about what we're talking about here. This is the acute phase. We're trying to modulate pain. We're trying to clean things up. We're going to talk more about these later in the day, but I feel like it's important to make note of these. We know that most individuals coming in have some degree of an imbalance between your omega-3s and omega-6s, and anytime you can get that omega-3 balance closer to 1-to-1 or 1-to-2, you're going to have more of a profound effect in what any other therapy that you're intervening with. And just sheer pain modulation, there is benefit in vitamin D for just outright pain modulation. So that can be another. Patients that have, especially muscle pain, vitamin D muscle pain is an indication for implementing vitamin D by itself. All right, let's move into our subacute phase, and many of the interventions, almost irrespective of what the tissue of focus is when we're in that acute phase, those interventions are pretty universal. It's in this subacute phase where we have to start differentiating these at. Our goals here are we want to continue to manage the inflammation. So just because we've hit 72 hours and we've transitioned into that subacute phase doesn't mean that the Intenzyme immediately goes away or the BioLay immediately goes away. Those need to be scaled based on what that patient's needs are. So it may completely make sense to keep Intenzyme, especially if you've got a severe injury. You're without question going to want to keep Intenzyme in there if it's something of that nature. We want to support the activity of the fibroblasts. We want to get those cells, those fibroblasts that are going to build the collagen. We want those as active and working at a high level, and raw precursors. Some interesting things on these raw precursors that we're going to talk about, I think you'll find interesting, but this will allow you to have an interesting conversation with the patient too. Some of the different intervention options, this is where we can begin to segment different types of tissues. We're going to see the Chondroitin plus. This I would focus on for more ligament type of applications. The Amino Sport is going to be a blend of amino acids here, including those essentials especially. And this is going to, if I've got a more muscular application, and then if I need to really address the muscle and the ligament together, the hydrolyzed collagen protein. I'm going to go through a couple of slides with you specifically on hydrolyzed collagen protein. This is one you definitely want in your back pocket. And I think that it's one that's easy to get patients to follow through on. And there's a couple of other advantages that are going to come along just from pure simplicity of utilization with that one that we can talk about.
Let me ask a question on those two, because I know with this chondroitin product, for a long time, because of the story about glucosamine, chondroitin molecules too big to get intra-articular, didn't do anything for you. So we kind of poo-pooed on chondroitin. And I just want to make that clear that for a ligament issue like this, it's very effective. Because I think a lot of people written off any type of chondroitin molecule because of that, the size of it.
You're ahead of me by about 2 or 3 slides. So hang with me. I'm definitely getting into that. That is an important conversation for us to have, and it's something we all need to be aware of. Chondroitin plus. Okay, a couple of nutrients here that you're going to have some base nutrients. There's going to be some B vitamins in there. There's going to be some minerals in there. In short, all you were trying to do with that combination of nutrients, those are the nutrients when we look at the synthesis of collagen. Those are the nutrients that have to be in place for us to endogenously synthesize collagen. That's all it is. They're the ones that are going to be stimulatory to the fibroblasts. We're also going to have glucosamine and chondroitin in here. I'll get to breaking those down. The idea with this is that this is the full complex that you need to start to repair joints, to start to repair that cartilaginous tissue. There's a synergistic activity in these. I think about in the context of synergy, why you would want that blend there. This is like getting in your car and trying to drive your car with no gas in the gas tank. Or me pulling out, if you got a V8, I'm pulling out all 8 pistons, you're not going anywhere, right? It's that, even though that is one component to a much bigger, more elaborate system, that one component shuts the system down. And this is the exact same conversation of why we want that synergy there. So building block for these injuries, but also notice on this, and I've mentioned this before, we've got these antioxidant enzymes. These are going to also help control those inflammatory cascades, keep those free radicals under control. And then there is going to be the glucosamine hydrochloride and the glucosamine sulfate. Let me tell you this, just so you can break these down. There's 2 products in the Biotics line. There's the Chondroitin plus, and then there's the Chondroitin S. The only difference between these 2 products is the Chondroitin plus uses glucosamine HCl. The Chondroitin S uses glucosamine sulfate. All it does is allow you to pick which form of glucosamine you want to use. There's literature to support both forms. I tend to go with the glucosamine HCl simply because I can get a much higher elemental dose of glucosamine with glucosamine hydrochloride versus the glucosamine sulfate. They both work. So don't get bogged down on that. The chondroitin sulfate, here's the differences on this. You will notice as you're looking at labels in the Biotics line that Biotics never says chondroitin sulfate in their line. It always says purified chondroitin sulfate. Therein lies the difference on those. Okay? So when we talk about the non-purified, which is by and large the majority of what chondroitin is out there, when you look at these, there's other compounds. So even though it is saying chondroitin, it is not just chondroitin. All the other compounds that are complex around chondroitin are still found in those chondroitin products. And the problem with that is that it makes a very large molecule. And hence, to your point, it makes it very difficult to absorb. So everything we have ever told patients about chondroitin and the low bioavailability on that is still just as true right now as it ever was. What is different on this is when you look at the purified chondroitin, it's an isolate from bovine trachea, from cow trachea. It's just a reliable, easy source. When you pull out that chondroitin from that trachea and you remove those other compounds through that purification process and you're only left with chondroitin, the bioavailability significantly jumps on that because you've got a much smaller molecule. And literally you go from 10% up to 90%. You can't talk about those two in the same context because they're truly 2 different structures with each other. So that's the reason we can pretty easily say that it moves up in the bioavailability. The reason this is also important here in terms of what it's actually doing is you guys will remember your glycosaminoglycan. So this is your protein-carbohydrate structures that we try to form that are ultimately going to give us collagen. That chondroitin is one of the primary components to that structure. So if we don't have that there, we're not effectively building those. And if we can get it in, it's smaller, we can get it assimilated, drive it down to those areas, then we should inherently see a better outcome from it. As far as what's being removed on this, a lot of your fibrous proteins, the collagen and fibrous proteins are what are being taken out here. Just a couple of pieces of evidence around what we're talking about. just so we're not flying by the seat of our pants and just saying things here. Notice on this, this journal is actually osteoarthritis and cartilage, so probably of any journal out there, these guys are more involved with this stuff, and the literature in this journal is going to be more specific to this. But notice in regards to what it says directly about chondroitin sulfate, prevents the joint space narrowing and reduces joint swelling and effusion. When noticing that reduces joint swelling and effusion, that's different than what we classically think about just as a repair or rebuilding tissue. So if it's having an anti-inflammatory activity, now it's multi-mechanisms that we're starting to look at here. Of course, it has anti-inflammatory effects on chondral and synovial levels, so maybe that plays a little bit into your question there. And then pleiotropic, just multiple mechanisms of action simply coming in there again. And then notice on this, the inhibition of nuclear factor kappa beta translocation, so moving from one area to another, it's going to inhibit that. And if you can knock down nuclear factor kappa beta, you can offset a lot of inflammation, because that is one of the key inflammatory cytokines that initiates the movement into a lot of the other inflammatory cascades. So it's very, very important to be able to do that. It also speaks to some of the ways that chondroitin sulfate is being shown to affect conditions that are not musculoskeletal conditions now. We actually see that there's evidence coming out in terms of how this influences viruses. What? Chondroitin sulfate influences viruses? Yeah, it does, because the mechanism of action on it is the reason it's doing that. This is going to be the graphical illustration that we're looking at here, but you'll see we can again see at multiple points where it's affecting the macrophages directly, because as that nuclear factor kappa beta increases, we're going to see some influence on how those macrophages are going to degrade those tissues. It also affects in the synovial areas there, so if you get into the synovial fluid, and then your articular cartilage, being able to protect that and maintain those joint spaces. This is something that, again, we may think about this as, or maybe we have classically thought about this as, it is simply a component to the repair process, and that's not exactly true. That's the reason it sits so nicely in that second subacute phase, because we're coming out of the acute phase where we're controlling the inflammation, but we're also moving into the repair remodeling phase where we do need to do some rebuilding, and this conveniently is going to be able to bridge that gap because of the pathways that it influences. Some of the additional nutrients that you will find in here, the sugarcane extract. I will tell you, I have noticed that when patients look at this, they see sugarcane and they get a little hesitant. Please point them to the fact that this is sugarcane extract. There's not carbohydrate in here. This is only in here for the purpose of the silicone. That's the reason we need that. That's going to act as a source of silica, and you need that silica to form as part of the base structure of your cartilage, your collagen, and ultimately, of course, those play into the bone. And the silica does play as a cross-linking agent as well. Manganese is both structural, and it's going to be a component to these antioxidant enzymes. Even though these antioxidant enzymes are provided directly, you will also see that the manganese is part of, we need manganese, zinc, and copper to facilitate our endogenous production of superoxide dismutase. So you get a well-rounded combination of ingredients in here at meaningful dosages. Amino Sport. This is going to go into more of our muscular type of application here. In regards to this one, amino acid formulations create an anabolic state. The anabolic state is probably the most significant aspect of that. There's different ways that we can do that, but we do know that certain amino acids facilitate that anabolic activity. I would look at this in two contexts. I would look at this in maybe an athletic application where we need to build some muscular structure, and then also in the rehabilitative phase where individuals have lost muscle tissue maybe as a byproduct of inactivity, and we need something to facilitate that. The branched chain amino acids in here, there is evidence with the branched chain amino acids that if you can get those incorporated in, that they will actually deter the atrophy of the muscle tissue. So anytime you've got someone who's at risk for atrophy, this is a product you absolutely want in the protocol here. Broad spectrum, again, your essential and your non-essential. And notice the dosing on this one is variable, so you really do need to assess and see what the need for that individual is. If it's a high metabolic need, you really need to offset that catabolic activity. 1 to 4 caps, 3 times a day. Same application here as what we talked about with the enzymes, in that this can be given 30 minutes before meals. Do you need to separate this from the enzymes? No. And the reason being on this is that these are amino acids. You're not going to break these down any further than what they're already broken down. The enzymes aren't having an impact on that. So these can be taken with the enzymes in scenarios where that does become necessary. When we need to address both the muscular and the cartilaginous, the ligament applications here, this is where we're going to get into the hydrolyzed collagen protein. And I want you to think about a few things on this, and you'll see as I go through this, the application is not solely related, or shouldn't be solely limited, I should better say, to musculoskeletal applications. But think about this in traditional diets, and I'll even give a little prelude to your evening meal. Think about what I'm getting ready to talk about as you go through your meal this evening, okay? So traditional diets include a consumption of cartilage, tendon, along with meat. Chicken wing is the easiest example I can consistently think of for this, right? You take that chicken wing and you're eating the drumstick part of that, you break it open, and because it's small, you're still going to have the cartilaginous end caps on that. Most people will eat the meat and then set that aside. Inherently, traditionally, what we would have done with that is consume the meat and then eaten the caps off of both ends, the articular cartilage, right? And if you don't do this, I incorporate this into my diet now, but if you don't do this, it doesn't have any taste to it. But you'll bite into it and it'll crunch, right? It's not like biting into a chip or something like that. But the point being is that even as I'm telling you this, you're like wrinkling your nose to me, right? But this is what we always used to do. This was part of how we consume food as humans. You don't let anything go to waste. I guarantee you, if I take that same substance and I provide it to my dogs who have an instinctual appetite, they consume it. They don't think about it, right? It's just part of what they do. So, point being on this is that when you look at our current modern diet, cartilage is not something that is inherently consumed in as part of our diet. That's a problem. We need it. So much of our body has a cartilage component to it. So when we don't consume those cartilage precursors, where are we getting it from? So just food for thought, no pun intended, as we go through this. It does provide more complete use of the whole animal, and again, the modern diet is going to be very centered on the meat component of this. And we know that if you look at the amino acid profile in the meat, irrespective of what animal source that's coming from, that is very different than the amino acid profile from the cartilaginous components. Just an illustration for you here. Anybody ever hear of bone broth? Right? This is what's going in the bone broth. It looks much different than the meat portion, right? And none of this is meant to be one or the other. That's not what the end goal in this conversation is, right? The end goal is how do we maximize the utility of both of those? And that's what we should be doing. So if we want to encourage change, ideally patients would consume more collagen just through natural food sources, but let's be realistic. I've got an educated audience in front of me and you guys are still wrinkling your nose, right? Even as much as you trust me and trust what I'm saying, you're still wrinkling your nose. All right, patients are going to be a much harder sell even beyond that. Some of the limitations on this with some of these food sources, there's going to be differences in the consistency on this, especially if you get into maybe some of these sources from like eating it in a piece of beef. Most people aren't chewing on a beef bone, right? Maybe a chicken bone, you might bite the end cap off of it, but you're not doing that with a cow bone. Not readily available in restaurants unless they're making their own broth. It's pretty much where you're going to find it in a restaurant. Outside of that, you're not going to see it anywhere. So we know that most patients aren't going to restaurants that are going to be serving a good quality bone broth. So you can pretty much check that one off for most people too. And anytime it's not the cultural norm, you got to push them out there and get them to expand their boundaries a little bit, step outside of the box. So point being on this is that when it comes to making a supplemental recommendation, you got a lot working in your favor on this one in terms of why you're probably going to get the sell when it comes to making the recommendation for this product. Human collagen, I wanted to give you a schematic so you can just recall. We've all seen this before. We all remember studying this from our basic sciences. But I wanted to give you just a recap on this. Keep in mind that it comprises 1/3 of the total protein. That's a significant amount of protein that we're talking about there. 3/4 of the dry weight of the skin. Who doesn't want to offset wrinkles, right? I mean, that's just another added benefit you can toss out there to somebody if you really need to close a deal with them. Your most prevalent component of the extracellular matrix. And then there's 3 defining strands, or you got these parallel strands that start to twist and wrap on each other. But there's 3 defining features in this in terms of the amino acids. You're going to have your glycine, your proline, and your hydroxyproline. Those are not consistently found in the meat portion of an animal. You have to get into the cartilaginous portion, the collagen portion, to be able to gather those. Now, specific to hydrolyzed collagen protein, we're looking at all 3 sources of collagen being utilized here. I would ask you, just for your own knowledge base and to be able to compare, look at other collagen products and make note that they use type 1 and type 3. That is a way of saying they use hide collagen, is what that is. What we're talking about here is pulling these amino acids from the bone, from the cartilage, and from the muscle tissue. We're not simply looking at only pulling these from the inner hide of the animal. All right? Now, collagen type 1, type 2, type 3, notice that these are very well distributed out through different areas in the body. So we really do want all the different types here. Again, another schematic in terms of what this, not just what it looks like, but how the process works. How can you even take a supplemental form of collagen and you'll benefit from that? Well, the way you do that is you have those collagen chains, they start to wrap, you have a collagen fiber, that's how we would find it, that's how we would consume it. And then because these are amino acids, when that goes into digestion, that's going to be broken apart. You're going to create disassimilation there. And then we start to restructure that in the body. And these are some of the patterns of how we restructure that. But you will also notice the proline, the hydroxyproline, the glycine, those are the consistent amino acids in those structures that we're looking for. So here's your option on this. Again, I would make note that this is coming from bone, cartilage, and muscle. Primary differentiating point from other collagen sources out there, chocolate and vanilla, and then 21 grams of protein per serving. And I will call this a protein because this is considered to be a complete protein. More on that in a minute. Your typical collagen sources out there are not considered to be complete proteins. So back to the clinical application on this, when I segmented this as your intervention for both muscle and ligament applications, that is why it is, because of that complete protein structure, is why you can yield the benefit towards the muscles versus only towards the collagen or cartilage. So it does span both areas. A couple of things to note about this: non-GMO, no preservatives, additives. It's checking the boxes that everybody wants to see here. And the other thing that's important to note about this is that the likelihood that someone, because this is coming from beef, the likelihood that someone's going to react to this is pretty low. The allergenicity profile here is much lower than what you're going to find with other powder protein sources. So even if someone just comes in and says, hey, I'm looking for a powder protein, can't do whey, maybe pea upsets your stomach, this is your option.
Okay, I was just gonna ask, there's no whey in this, no milk or dairy in it?
Nope.
Lactose.
Yep. So no, it doesn't have whey, it doesn't have casein, it doesn't have any of that in there. The other thing that's important to note about this product in the manufacturing process undergoes what's called hydrolyzation. And when they hydrolyze these different amino acid chains, what they yield from that are different size peptides. You have some peptides that are very small, which means a small peptide, once we ingest it, doesn't need to be broken down of any significance. It gets assimilated very quickly. There's moderate-sized peptides. They need a little more work in the digestive system. They are assimilated at a more moderate pace. And then you have very long peptides. They take much longer to digest. So you're going to get a much slower administration on this. This has whereas whey protein has a fast curve in terms of intake, utilization, and then you better look for another protein source pretty quick. You're not going to run into that here because that curve doesn't spike and come down. That curve is a flatter curve as a result of that, right? And that's not a comment to knock whey protein. There's a reason you use whey protein and you use that spike, but you have to know how to use it. That's not what we're interested in here. What we're interested in here is we want that flatter curve because we're more interested in the anabolic activity, the cartilaginous repair from this. You don't need a spike in that protein curve. Just as a cute aside on this, there's 3 of those out in the pasture now that are about 6 months old. So you guys have got to see these. They're beautiful cows. So sourcing on this from these animals, hormone-free, antibiotic-free, non-GMO, grass-fed Swedish cows. Swedish cows are known to be pretty healthy cows. Right? And these are the things that you want to see. These are the things that I want to see. Interestingly enough, too, just as a total offshoot on this, in the cold season, they use the non-GMO silage and hay with these animals, so they're maintaining the same standards in the cold season as in the warm season with these animals. So regardless of when these animals get harvested, you're getting the same yield from them. A couple of other things to note about this. I mentioned the hydrolysis process on this. You do preserve the amino acids and the peptides. There are a few vitamins and minerals in there as well as a byproduct of that. You get a high branched chain amino acid profile. That's the reason we can call this anabolic. It does stimulate muscle development here. Nitrogen score higher than whey protein. That's saying something. Whey protein is pretty doggone good protein for creating anabolism, and it's known to have a high nitrogen score. This is actually even above that. And it is easily digested. I don't think I've had anyone push back on me in terms of this is creating any GI distress. And I haven't seen that with my own patients, and I haven't had anybody say that to me. Aging, these are just some additional things outside of what we talked about. Of course, the stiff and achy joints. Maybe someone gets up in the morning and, it takes me a little while to get out of bed, get moving. This should be a consideration, and then a couple of other options here. Something for us as diagnosticians, the thinning hair and brittle nails could be a strong indicator to tell you the patient probably needs this. Those can be indications to tell what the capacity for healing for that individual could be. And this could be just something to give you some guidance in what your recommendation needs to be. Ideal applications here, again, sensitive to dairy, mouthful in it, very smooth, consistent protein source here. So this one should go down pretty easily. Muscle gain, GI support. The enterocytes in the gut actually do produce collagen. You're directly supporting the gut activity by consuming that protein source that has that high load of the proline, glycine, and hydroxyproline here. And slower aging, who doesn't want that, right? Oral administration, I put this in here just to show you evidence that the literature does substantiate the application of these. And this is a pretty recent study. This is less than 2 years old here. Abundance of preclinical and clinical reports provide evidence for collagen hydrolysase, which is what that is, hence hydrolyzed collagen protein, improvement of dermal health, oral administration via nutritional products. So that's clinical evidence that the oral application of that protein source will create effect. And then just to give you dosing guidelines on these, you can see 3 caps twice a day here, and then so on and so forth. Remodeling phase, our last phase that we need to discuss. And this is probably, of all of these, this is probably the easiest phase to try to manage, if you will. Your goals, continue to support delivery of the precursors for healing. Again, some of those products that we just talked about, for example, maybe the Chondroitin Plus, that would potentially carry over into this segment as well. We wanted to develop structural and mechanical integrity as you're going through the later phases of your musculoskeletal care. That's where we're really starting to think about aligning some of these products in. And then prevent re-injury. We know that tissue, once it's been injured, is never going to be 100% again. But whatever we can do to get it back as close as possible, we want to try to do that. So we want to prevent that re-injury. Some of your intervention options here, previous ones that I recommended, Purified Chondroitin Sulfate and Chondroitin Plus. I'm going to differentiate these for you in just a moment, and then I'm going to introduce to you KappArest. Let me give you a graphic here of osteoarthritis again, and some of the things that we have to think about on this and what we're doing as we're moving through. And I want you to go back and think about some of the interventions we've talked about up to this point. These inflammatory mediators, this is where we're going to come in definitely with the Intenzon, but also maybe with that BioLA to start to get this under control, calm down the inflammatory process, modulate the pain as necessary. If the patient's not complaining significantly about pain, there's really not a reason to use the BioLA unless they just have a negative response to the Intenzon Forte. I would use the Intenzon initially, and if there's that pain component, pull that BioLA in. Cleaning up, we want to go through the debridement component here, and then we want to get into the remodeling phase. So just a flow chart there of what that should ultimately look like for a lot of these patients. Now, Purified Chondroitin Sulfate. I personally think this was a game changer. I tore my knee up about 2 months ago, pretty good. I was hobbling around here. Let me tell you, doing farm chores, hobbling around is not pleasant. Yeah, poor Leah, right? She took some of the brunt of that injury. But the Purified Chondroitin Sulfate, I feel like made a complete difference. Getting the right rehab, of course, you got to have the biomechanical component to it, right? But I feel like that, along with the Purified Chondroitin Sulfates, and I've continued on these, I feel like that made a difference. And if you've got these patients that are coming in, you've got a disc injury, and you know that you've got them out of the acute phase, they're pretty good, they're back to their activities of daily living, but you know because of understanding the repair phase here, that remodeling, it's not done. They're 3 months out. They're not 12 months out. So we need to keep something in their protocol that's going to support that. And if we can do that with the chondroitin, keep the inflammatory cascades under control, provide that chief glucosaminoglycan in there, and notice on this that it's going to increase white blood cell counts. Just to make things 100% clinically relevant here, patients a lot of times are stressed. Patients, most of the time, are stressed, right? Is the reality of that comment. And as a result of that, if that's been lingering for an extended period of time, that suppresses their white blood cell count. They'll have white blood cell numbers under 5.5, under 5. This can be something to pull the white blood cell count up. So you get not only the benefits of the musculoskeletal application, but you're also getting systemic benefit from this as well. Dosing options here, I would say at least 2 tablets twice a day for more of a maintenance and extended dose here. But even if you got someone, I'm gonna pick on you for a minute because you're a warrior, man. You're gonna tear your body up. We've had this conversation, and my wife's sitting over there laughing because she knows I do the same thing. We're going to work out, right? And it's just the nature of who we are. And we're gonna do things. We want things to be able to maintain our joints. This is something that we can do. So for the weekend warrior type that comes in and they need that ongoing, consistent repair, the Purified Chondroitin Sulfate, that's the direct name of it, is what I would employ. Now there are options, and let me differentiate these. And if you don't want to differentiate, just go with Chondroitin Plus as your in-clinic repair in that subacute phase, and then move to the Purified Chondroitin Sulfate in some of the later stages. The Chondroitin Plus is, if you will, in the middle of these two. It's a little bit lower dose on the chondroitin there, on the Purified Chondroitin. It's 250 on the direct Purified Chondroitin. It's 200 milligrams on the Chondroitin Plus. Plus you get some manganese and B12 in here. Manganese, B12, as you need to turn over tissues. Most people are going to benefit from that. But if that patient's already on a multi, you're not suspicious about a B12 deficiency, they don't have the red spots on the tongue, or they don't have the thick, beefy tongue, just as an example of a way to see that. They don't have a megaloblastic anemia. Maybe the Chondroitin Plus is not the best option for that person. Just give them the direct Purified Chondroitin, and that's the precursor that they need to continue to heal. Now, KappArest. Many of you are familiar with your antioxidant full spectrum blend. This is what we're going to use in place of that. This is, by nature, as there's a lot of applications here, so I'm going to expand on some of these applications for a minute. As the name implies here with KappArest, NF-kappa beta, that's our target molecule, and we're trying to arrest or calm down that NF-kappa beta. I talked about earlier how this cascades out into other inflammatory cascades. Interleukin-6, C-reactive protein, we've seen that. Our cyclooxygenase pathways, which move into production of our thromboxanes and our prostaglandins. Your lipooxygenase pathways. I talked about the TNF-alpha a little bit earlier. Your adhesion molecules, that stickiness that starts to become created. If you can shut down this, the activation of NF-kappa beta, which all the ingredients in this product are by design intended to do that, you can directly affect all of these inflammatory cascades. So instead of working out here, further downstream, start at the base of where the problem's are originating at. And that's what the NF-kappa beta does. Now, this is another product that can be scaled on dosages. I really haven't seen a need to go over 3 caps 3 times a day. That's a fairly aggressive dose. Most patients at this point are probably going to be in the neighborhood of 3 capsules 1 time a day or 1 capsule 3 times a day, just 3 total per day. But if you know you've got someone who has some type of chronic disease that's a contributor or at least underlying their physiology, I would put them on at least 3 capsules twice a day for that. So, and for those of you that do the micronutrient testing, you have the patients that have the Spectrox scores that are under 66%. This is what we're using now to be able to control that very effectively. Everything I have talked to you about today in terms of how the botanicals influence the production of glutathione peroxidase, superoxide dismutase, and catalase, the compounds in the literature that are talked about to be able to do that, the EGCG from green tea, the resveratrol, the boswellia, are all found in this product. So this is not just about directly giving those modulatory botanicals, you're also upregulating your own endogenous compounds there. You can see, these are things we want to see. Curcumin, boswellia, green tea, rosemary. I mean, that's a rock star combination.
Also, Arland talked about the viral, having the viral issues, and I have 2 patients with chronic shingles, like years, and this is the only thing that's given them relief. And they'll take it twice a day generally, and it takes care of it.
Perfect. Okay. Other considerations. I put this list in because this is going to be the list that is just going to be your default when somebody's complaining about these things. Where do I go real quick? If someone has cramping, the BioCMP, this is calcium, magnesium, and potassium that we're looking at here. I want to show you something interesting on that too. Muscle spasms, VHP, valerian, hops, passion flower is what that acronym stands for. Those are all neuroinhibitory compounds. Your topical pain relief. If someone has an injury and you just need something directly that you can apply that, this roll-on relief, which is a full spectrum phytocannabinoid, great direct topical application. Anytime you've ever used, for example, BioFreeze or something in that category, this is a good intervention to use. If you have a very severe pain patient, I would recommend bringing in either the liquid or the capsule version. Seen some really interesting things. Even one of Crystal's friends was reporting back to me last week about utilizing the capsule version on this. She has recurrent low back pain, and she was using the FS15 to be able to control that back pain, and she was able to maintain her activities. Whey protein isolate, right? So we do want the whey protein isolate when it makes sense, but if we're looking to predominantly focus on muscle, I would go whey protein. If I'm looking to try to have an option away from whey protein, the hydrolyzed collagen protein, or if I'm looking to focus on muscle and ligament, hydrolyzed collagen protein is my best intervention. And then the curcumin RX, if I need an isolated anti-inflammatory. You give someone KappArest, I mean, this is just clinical management. You give someone KappArest, they don't respond well to it, they're concerned about, oh, I reacted to something in there. Okay, let's start differentiating the components in that. You'll recall that the initial ingredient in KappArest is curcumin. This is the exact same curcumin that's in that product, so we can use curcumin RX, which is an isolated source on that. This has been tested for your benzenes and toxicants that are commonly found. Remember, I talked about earlier how much emphasis they put on the lab process. So this goes through the lab process of being assessed for a lot of those toxicants that are common in some of the supply chains for curcumin. So that is not present in here. And I do want to just elaborate on something with the BioCMP. And really, this is more of a broad application of minerals. One tablet, would you look at those dosages for calcium, magnesium, and potassium? Who in here, by show of hands, would say that those dosages are high? Would everybody agree that those are low?
Yes.
Okay, as would I. But what if I told you that there's actually 200 milligrams of calcium in that product, as we have classically thought about calcium? Here's an important thing that we need to know. When we look at calcium on a label, notice it says as calcium gluconate. There is only 18 milligrams of elemental calcium in that product. There is 200 milligrams of calcium gluconate in total, which means that there's 182 milligrams of gluconic acid. You guys see that? So when you see these numbers that are often represented, you see it's represented down here. 200 milligrams is what you would most of the time see on the label. You're not generally seeing 18 milligrams. This is no lower of a dose than what you're going to find in a comparable product. It's just written different on the label, and it's more transparent about what you're actually getting. Okay? So just be aware of that as you're looking at these labels. So don't get shied away because you see a low dose of an ingredient in there. It's the elemental amount that you're actually reading there.
I'm glad you brought that up because we were ordering B12 from Biotics, and if you compare the Design for Health to the Biotics bottle, it's like a huge discrepancy. And so that was our question of why would we pick something with a lower dose, but that explains it.
Yeah. It's the best examples are in the minerals, and again, that's the reason, thankfully, that they delineate that down here, that you do need to be aware of that, because if somebody, that's again one of those things that's easy to push back with, but it's all about transparency too, right? Let's be upfront and tell you what we actually have in here.
And I think that B12 is also the form.
What it is, it's different.
So the methylcobalamin maybe isn't as great as we thought. The hydroxycobalamin is showing to be more effective across the board for anybody, whether they have MTHFR or any type of pathways, issues with that. So it's still showing to be as effective.
Just a couple of tips for your management as we move in here towards the end. How many of you, when you're setting up your musculoskeletal application or musculoskeletal protocol, and you're discussing that with a patient, how many of you waffle on what you're saying or are hesitant in what you're saying to the patient? Just Reese. Just Reese. Okay.
Glad you're in training.
Yeah, you're in training. We'll get you out of training one day. Point being on this is you don't. When you make that recommendation to the patient, you're very emphatic because you're the doctor, you're the provider, and they came to you because they trust in what your recommendation is. This is bar none one of the biggest problems I see with people trying to make recommendations for nutrition. They halfway make the recommendation. If you think they need the product, make the recommendation. Don't halfway do it because they smell it all over you, right? Don't do that. You need to reiterate with the patient. It needs to become part of the conversation. It doesn't need to become the conversation. It just needs to be part of the conversation. They don't want to be browbeat with it, but they do need to be reminded. I would also say, just as you're having these conversations, the patient's coming in for their follow-up, chart. For you would chart it, but let the patient know in their care where they're at. At what point is it time for them to start thinking about a transition? You laid out that initial recommendation when you sat down with them and did the report of findings with them, but they're going to need touch points, they're going to need reminders as they're going through the phases of care. So just make sure you communicate and make that firm recommendation. Don't be hesitant, don't waffle back and forth.